some time for questions at the end of the session. So in your program you'll see that Dr. Champlin is listed to give the next presentation, but he is unable to. So we are again very honoured to have Professor Shpall with us from the MD Anderson today, who is a leader in transplantation generally, more specifically cord transplantation, and the opportunities and challenges that that type of transplant faces with respect to cellular engineering and cellular therapies. But today she'll be talking with us today about the opportunities to consolidate or improve outcomes and prevent relapse after allogeneic transplantation for AML. Thank you.
Thank you very much, Dr. Ritchie, Dr. Moti, and I'm very sorry that Dr. Champlin couldn't be with us. He had a terrible viral syndrome and sends his regards. And so what we're going to talk about today is this is his talk on allotransplantation for AML. So clearly you've just heard that allotransplantation is an effective treatment for AML, but relapse is the major cause of treatment failure. And the risk factors for relapse include adverse cytogenetics, molecular risk group, older age, therapy-related AML from other cancers or AML arising from myelodysplastic syndrome, and importantly, minimal residual disease following the transplant. You can see here in the survival curves, and you heard so elegantly from Dr. Tien and Dr. De Lima, that FLT3 positivity, this is the overall survival for patients with AML and CR. FLT3 positivity confers a worse prognosis. Core binding protein is intermediate, and monosomal karyotype worse than monosomal karyotype negative. It's clearly impacting survival. MRD can be assessed by molecular detection of AML using mutations or translocations. And MRD by flow or PCR clearly predicts a higher risk of relapse, both after standard chemotherapy, as you heard earlier, and also after transplantation. In this slide by Buccisano, which doesn't show up very well, he looked at a subgroup of patients with AML, 143 patients, stratified according to pretreatment karyotype or FLT3 status, and the levels of MRD by flow being 0.035% higher or lower, and looking at overall prognosis. And as you can see in panel C, if you're FLT3 negative and MRD negative, you have a much better outcome, disease-free survival, than you do if you have an abnormal karyotype FLT3 status or have evidence of MRD by flow. Walters and his colleagues published just recently a similar relationship. This is post-transplant now, outcome for patients in morphologic remission who had MRD. Again, by flow, you can see the overall survival, disease-free survival, clearly higher for the MRD negative compared to positive patients with a higher relapse rate, as shown here. So what are the strategies to prevent this MRD positivity? We could give better ablative regimens, and many groups around the country are trying to optimize on a more intensive attempt to eradicate AML. The group from the Hutch are looking at radioactive monoclonal antibodies targeting CD45, which look very promising. A second option is to try to modulate the graft versus leukemia to make it more potent, although that is a difficult strategy given it's very hard to separate the GVH from the GVL, as we'll talk about. Cellular therapy is burgeoning in our country and elsewhere because there's a number of different cell types now that look to be very effective, natural killer cells and T cells, which we'll talk about just briefly. And then you heard from Marcos about post-transplant hypomethylating agents, and we're going to talk about that just briefly. Natural killer cells are being looked at by a number of groups. Jeff Miller and his colleagues at the University of Minnesota have pioneered the use of natural killer cells to eradicate AML in patients who had refractory disease. The responses were transient, but now many groups are trying to improve upon natural killer cells to make them more potent and make the responses more durable. They are the holy grail of the transplant community because natural killer cells actually target the tumor. And they also target the antigen-presenting cells of the host, of the patient, so they abrogate graft versus host disease without compromising their ability to kill those leukemic cells. They don't need to be sensitized, unlike T cells. So at MD Anderson, we have a number of major projects looking at natural killer cells. Dr. Champlin and Dean Lee are leading this trial with peripheral blood-derived natural killer cells, either from a haplo-identical donor or a sibling donor. And with this blood draws, we expand them in a wave bioreactor. We get massive expansion and are infusing these now. Just started and are going to be infusing these post-transplant to patients with high-risk disease. The other project for patients who have cord blood as an option actually is the generation of cord blood natural killer cells. Here in both the peripheral blood and the cord blood, our unique expansion strategy involves a K562 cell that Lawrence Cooper provides that has 4-1BB and IL-21 on the surface. And this is a very impressive construct that allows for massive expansion of both peripheral blood. And in the cord blood, we have a small bioreactor and are getting very good expansions here. If you look at the phenotype and the function of these and the receptors that they express, this is work by Katie Rizvani, who's joined us about a year ago. You can see that both the inhibitory and the excitatory receptor profile is very similar for expanded cord blood versus peripheral blood. They kill tumor targets similarly. And importantly, on the bottom of the slide, the cord blood cells don't have a good expression of mesodermin and T-bet, suggesting that they are clearly not exhausted and able to kill. Similar studies for peripheral blood are ongoing. But this is good preliminary evidence that they may be effective in our patients. And the studies with cord blood natural killer cells we'll talk about tomorrow. So are we able to separate graft versus host disease, which is a very broad event where the T cells target the liver, the gut, the skin, as well as leukemia, whereby the tumor cells that actually produce GBL target simply the leukemia. And it's very hard to date to try to separate those two. So a very exciting strategy has been developed by Malcolm Brenner and his group at the Baylor College of Medicine in Houston using Inducible Caspase 9, which is a self-destructing switch. And I'm sorry I don't have the, let's see, if I use the pointer here. If you see here, the Caspase 9 is actually placed into retrovirally transduced into the T cell and sits there quietly. And then when a dimerizer, which is AP1903, is given, you can see what happens is that the Caspase 9 dimerize and activate the caspase system. Caspase 3 is cleaved, and what we have is induction of apoptosis, and the cells are destroyed. In a really beautiful study that was published in the New England Journal in 2012 by the Baylor group, you can see on the top, the patients had haplo-identical transplantation and were infused with the donor lymphocyte infusion. You can see in the graph on about day 42 following the infusion, the patients developed total body rash. They were given this dimerizer, the AP1903, and you can see in the graph, within hours, the T cells were dramatically reduced, and within 6 hours, the rash was gone. If you talk to the clinicians who are taking care of the patient, it's the most amazing eradication of a GVH rash, and this has occurred now in every patient who's received the cells. So very exciting and a safety switch moving forward. So what is the ideal post-transplant therapy? You need a therapy that's active against the cancer, that's not toxic, that causes little myelosuppression, and perhaps can enhance the immunogenicity of the malignant cells as well as the immune anti-tumor effects. Hypomethylating agents you just heard about from Dr. De Lima and Dr. Kornblau. They're active against AML and MDS, although for Dr. Kornblau not terribly active, but perhaps more active in the transplant setting. They are definitely something that is being developed by a number of groups. So John DiPerzio's group and many others have shown that they have very important immunologic effects that have yet to be confirmed in the clinic, but look very intriguing. They increase the expression of tumor-associated antigens and increase the expression of KIR ligands on hematopoietic cells, making the potential for an NK cell benefit more prominent. The tumors have reduced expression of class 1, 2, and 3 antigens on their surface, and the hypomethylating agents actually upregulate those antigens to allow a better attack from the NK or even the T cell. They definitely increase expression of known minor antigens, which may be important when we're giving cellular therapy. And finally, increased FOXP3 has been shown by a number of groups shown on the bottom of the slide, which may, in fact, in the transplant setting, abrogate graft versus host disease without compromising the GVL effects. So Marcos de Lima piloted the use of azacitidine, post-transplant azacitidine maintenance, and in a phase 1 dose-finding study, identified the optimal dose to be 32 milligram per meter squared, with what looked like promising results in heavily pretreated patients. 96 cycles were delivered safely to these patients. And as you can see here, the relapse rates in this 6-month landmark analysis, relapse rates, the cumulative incidence of graft versus host disease, favored those patients who got more than 3 cycles of the azacitidine post-transplant with a statistically improved outcome compared to those who got either less than 3 cycles or no azacitidine. And this very promising data has spawned a randomized trial, which is ongoing now, and I think we've accrued about 2/3 of the patients and continue to look at this. John DiPerzio's group again showed in 27 transplant patients with a median follow-up of 7 months that induction of an increase in Tregs was shown, both in the sibling and the MUDs in the early post-transplant period. They induced a memory T-cell mediated response to a number of different antigens, including WT1, PR1, the myeloid antigens, which would be important for AML. And 80% of those patients who got 6 cycles of treatment or more had very impressive CD8 T-cell responses to their tumor-specific peptides when studied. And again, this group is continuing to look at this. So what are the candidate antigens to give post-transplant that might potentially eradicate relapse? You heard from Steve Kornblau about a number of FLT3 inhibitors. They may be more effective in the post-transplant setting than they are as single agents up front, and a number of groups are looking at sorafenib and AC220, the data to be forthcoming. Histidine deacetylate inhibitors and other hypomethylating agents, including decitabine and SG1110, are all in studies now with the data forthcoming. Oral azacitidine as well. Lenalidomide and other IMiDs look to be very effective in certain settings and are being studied post-transplant, and vaccines against leukemia-related antigens, PR1 and WT1 specifically are being looked at. So this is data from Jeff Moldren of our group, who studied for many years PR1 CTLs and has developed a number of different strategies targeting T cells that express the PR1. And in this very intriguing data on the right side of the curve, you can see he puts PR1 into cord blood cells and gets very impressive eradication of AML in his mouse model compared to controls, and is developing a number of different strategies, including PR1 CTLs and a chimeric antigen receptor targeting PR1 with this approach. And you heard from Steve, he showed you about chimeric antigen receptors. They are clearly an exciting novel approach that is being looked at in many different centers. The possible targets, as you heard from him, are CD123, CD33, and others. The group from Carl June and the University of Pennsylvania have very impressive data at ASH with CD123 in the preclinical setting. The problem with these chimeric antigen receptors is that there are a lot of off-target effects, so that they affect not only the cancer cells, the AML cells, but also the normal hematopoietic cells. So this may be an ideal agent to use in the transplant setting to further improve our ablative regimens with a transient transduction, for example, in electroporation, so that it will come in, affect the cells and be gone, and then we'll give a donor graft to protect against the off-target effects of myelosuppression. And a number of such studies are being planned. So I'll conclude by saying relapse remains the major cause of treatment failure. Novel therapeutic approaches are needed to prevent this. Approaches include hypomethylating agents or molecularly targeted therapy, immunologic approaches, CAR T cells, NK cells, and controlled clinical trials will ultimately be needed to assess the benefit of such strategies. Thank you.